Yeah. Well, yeah. I mean, air is a part of our
Hello, everybody. First, I just want to thank Dr. Wonky and the ACR for the invitation to be here. We're excited to talk to you about what we do and how we do it. I think most of the presentations there, a lot of them were around the benefits of follow-up and what economic impact there is, the patient outcomes, all that. And I think we can all agree that there's big impact there. But what we're going to talk about today is implementing your follow-up program. I think that's one of the biggest questions that a lot of people have is this something that's really hard to do, or is it something that can be really easy to do? And that's what we're going to focus on. So here's your cheat sheet. How to stand up a live follow-up program in just a few weeks. And within health, that's really what we pride ourselves on, is making this simple and easy to do, get you up and running in just a few weeks in really any environment, whether you're a hospital system or private practice. Finding the ways to do that in a flexible and quick manner. So, for this presentation, we're going to talk about a few different things here. The way we implement the follow-up program really happens in three phases. First is assessing the current state and opportunity for your practice. Where are your gaps? Where have you been missing out on patient adherence? Where have you been missing out on ROI and economic impact? Doing an analysis to show you with your own data what that looks like. Then it's drafting a business case. So talking about things, how many patients can you bring back in a given year? How many follow-up recommendations are you giving? Which referrers are sending more back than others? How many FTEs is it going to take? Is it going to take 0? Is it going to take 10? Is it going to take 1? What's that cost going to look like? How much can you save? And then how do you get project approval for this? I think that's one of the other things. How do you pitch this to leadership if you're not leadership? And how do you prove to yourself that it's working? Then we'll talk about the business and technical decisions that need to be made. That's usually our second phase. Working with a practice to kick off the project, talk about what is messaging going to look like, what are the cadence of how we're going to interact with you and your patients, and then documenting all these things to go forward. And then finally, how do you get it live? How do you start the process? How do you start engaging patients, providers, getting follow-up to happen, measure that, train your staff, train your referrers in some cases, and then how do you improve that over time? So these are the three main areas that we go through with our clients and talk about here. So phase one, assessing your current state and opportunity. We typically allocate about 2 weeks for this, and that's pretty quick in lightning speed. Really what we do is we answer a couple questions. What's your historical situation look like? What's your follow-up compliance been for your practice in the past? What are the financial, quality, and risk implications of lapsed follow-ups for your practice? So there's a few key activities we perform. First, we perform a historical analysis. Typically, we look through about a year to a year and a half worth of your past data and identify gaps. So we're looking for things like how many patients got recommendations, how many came back, break it down by modality, break it down by anatomy, break it down by referring physician, even your own radiologists, and what are the quality of the recommendations that the radiologists are giving. That's an important factor. We often see more specific recommendations result in better follow-up rates. So giving you that information where you can make decisions about that. To do that, we get BAA in place quickly, and we run the report. You give us your data, we complete a report for you, and put that together in just a couple weeks. The second part of this phase is drafting that business case. So once we do that analysis, we look at the ROI opportunity. And I think we saw some of this. Regan, your presentation was great and showed really where that comes in. Giving it to you for your own practice, showing you what your opportunity is, and providing that in a digestible form. And then how do you get approval and executive sign-off? So that's really what this all boils down to. Being armed with the data, being armed with what the gaps are, what the problems are, how your patients are performing in terms of follow-up, and then what the opportunity is to improve that. How much can you improve your practice from an economic and patient safety and quality of care perspective? Putting that together allows you to speak to leadership and make the case for implementing a program like this. All right, so some tips and tricks for phase one, things that we've learned along the way. We've done this with quite a few practices across the country, hospitals and private practices. And just some things that we've learned that may not come out in the documentation here. But one of the most important things is to have clear goals and be vocal about them. Talk to the vendor or the vendors that you're considering, and make sure that they can measure the things that you're looking to improve. and also have a clear understanding of what those things are. Is quality and safety a priority? Financial, risk, what are your priorities and how do you want to measure them? And make that very clear from day one. The second most important thing that we found, the more successful practices are able to identify and empower an internal champion. Someone who's going to take the reins on this, drive it, cares about it, and is motivated to make sure that this happens and you see results. We've seen practices where people don't necessarily want to be that person, and you get a lot of finger pointing and really no movement. But if you can find that person in your practice, that's going to be a huge advantage for you. And then lastly here, get technical buy-in early. I think everyone can agree that over the last couple of years, IT staffs have been stretched really thin. It's not just in follow-up, it's across the board. You're putting in new phone systems, you're updating your packs, you're controlling your risk. If you can get buy-in from your IT team quickly, let them understand that this is not a heavy lift, and get the quick approval for this, your life will be much easier and much easier to get this program set up. Phase 2. Business and technical decisions. So once we have buy-in from the practice that they want to do this, there's a problem to be solved, and there's an opportunity that they want to go after, and we've got contract signed and we're moving. The next phase is put the project plan together. So this typically takes about a week. We sit down with leadership or that motivated individual, the champion, and determine what recommendations are we going to target first. Do we want to start small? Do we want to start across the board? What will that workflow look like? Is it fully automated? Do you want to have a care navigator or some type of FTE in the loop? And what's the best mechanism to share both the historical and the prospective data with your teams? So really 3 components to this as well. We conduct a kickoff meeting. We work with stakeholders, align on the scope and expected outcomes. This includes figuring out the project approach, talking about messaging. How are we going to communicate with patients and providers? What are the rules of engagement for us and you? How often do we want to connect and discuss results and improvements? Documenting those business decisions, so figuring out what the recommendation focus will be. How are we going to communicate? What's the sequence of messages? Are we going to do patients and providers, just patients, just providers? How are we going to do change management? We're going to reach out to referrers beforehand. And I think, like Ben mentioned earlier, you've been mentioned earlier, and Regan, you too. Referrers like this stuff. I think everyone's been a little afraid of referrer reaction for a long time. One of our clients, they have 800 referrers in their network, and we sent out a communication beforehand that this program was going to be implemented. 4 referrers opted out of 800. 2 of them happened to be the same person with 2 different practices. So that's a pretty good rate of approval, and since then, anecdotally, nothing but positive feedback. Thank you for reminding me about these things. Thank you for taking the pressure off my plate and engaging my patients. So a lot of positivity there. And then documenting the technical decisions. So the historical and ongoing data exchange. Typically, we use HL7 interfaces, make it really simple, get that stood up very quickly, and we have standard templates for setting up those data exchanges and making that happen. Some tips and tricks here on phase 2. Keep it simple. You don't have to boil the ocean right away. You can start with a single modality or single intervention or a subset of recommendations. We have the ability to filter down who we want to communicate with and engage. You can see the data across the board, but if you only want to communicate with patients for chest CT follow-ups, for example, you have the ability to do that. The recommendations that you may not be sure about, right? If it's a smoker, high severity, they need a recommendation. You have the ability to filter those out as well. Determine how you want to handle those. Do we want to communicate with them? Do we want to communicate with them at a certain time? Or do we want to put them in a separate bucket for maybe a care navigator to handle? You have the ability to do that. So start small, keep it simple, and grow into the program. Edge cases are important. They're always going to be there. Everyone likes to point at them at first when they're evaluating vendors and programs, but don't let them stall the process. There are ways to deal with them. You can bucket them, you can determine how you want to handle them on an automated basis or allow a human to deal with them. But edge cases are exactly that, edge cases, and you don't want to derail your entire program because of that. You can deal with them as you go. And nothing is set in stone. Don't get paralysis here. These things can be changed day 2, they can be changed year 10. That's really the point here, is make this a learning process, make this a growing process. Your practice changes over time, your follow-up program will change over time, and nothing is forever. You can learn and adapt as you do the program. So, phase 3, how do we do this? Get it live and start improving. So some of the questions that we like to ask here are, how do we best support your care coordinators or whoever's managing the program, practice administrators, and how do we ensure a tight relationship between us and your practice and continuously improve it? So again, 3 key activities. We get those feeds stood up, we test them, we launch them, make sure the data is coming through in the right format, work with your tech team very closely and quickly to get that to happen. We conduct some simple user training sessions, so if you're staffing someone on the application, show you how it works, show you how to communicate with your patients, how to set up automated campaigns, how to manage the program. Very simple, intuitive, really doesn't take a lot of training here, but it's always good to hit the ground knowing what you're doing. And then lastly, we apply a performance improvement framework. So we monitor the performance of the system over time. See how many recommendations you're getting on a weekly, monthly, annual basis, how many are coming back. Continuously improve natural language processing, which is the core of our platform. We take feature requests, we work with you. Every practice is different, so we want to know what's important to you and how we can improve that. And then finally, executive level reporting. So you're going to have to show someone that this is working and the investment is worth it, and we help you get there too. Show you a breakdown really across the board, modalities, anatomies, refers, how your radiologists are performing, what your ROI is, and make that very clear for you. Tips and tricks here. Define your measurement framework. Be very clear about what you want to measure and how you want to measure. There's lots of different ways to do it. You don't need to do them all, but you need to be clear about what you want to do. You want to measure adherence compared to a baseline in the past. Do you want to measure trends over time? Do you want to see patient outcomes? Just understand what you want to do, and we can work with you to make those decisions on best practices, what we've seen in the past. As far as selecting users for these programs, the people who are going to be interacting with it, we found that the most successful practices use staff people on this that have comfort level with patients. This is a patient engagement tool at the end of the day, right? You're dealing with patients and providers. You're trying to get them to change their behaviors. You need someone that is comfortable doing that and comfortable being in front of those people. And don't be afraid to experiment. Measure, be vocal, work closely with your vendor. Find a vendor that can give you as much time as you need, and will hold your hand or be available to listen to what your needs and concerns are. You want them to iterate quickly. This is important. It's your patients. These are the lifeblood of your practice and your refers. Make sure your vendors are able to give you the time you need. And just a little bit about us before we wrap up. What we do is our product is called RadNav. Really 3 components to it. We identify lapsed recommendations, lapsed patients. We have a natural language processing platform and some AI algorithms for you buzzword people. And what we do there is we identify the patients that have misrecommendations. So we're looking for what you're dictating by time frame, modality, anatomy, and then we engage those patients and the care teams through digital channels, text message, email. We can communicate with refers, communicate directly with patients, really up to you how you want to set up your campaigns. We obviously offer best practices. And we ensure the continuity of care, so auto case closure. When we see patients complete those recommendations, you don't have to have a human reading through reports to make sure, oh, this person did it. We can automatically close up those cases, let you know that the patient's been taken care of, and you continue doing what you do best, providing patient care. Typically, our customers see a 50 to 60% improvement in follow-up compliance in sometimes as little as 6 months from launch of the program, and obviously a huge ROI comes along with that, as we saw earlier. So I don't know if there's question and answer time here or not, but
unfortunately not.